Okay, good morning, everybody. It's 11:40 on Sunday, October 15th. And as we had mentioned, we're going to record and post, which you found, obviously, if you're listening to this, a recording about bipolar disorder, assessment, and treatment. This is coming from the static readings and some Thapar and Pine for the pediatric uh, considerations, which we will again revisit in the spring. And from Stahl. Stahl had some chapters on mood disorder, not only bipolar disorder, kind of the theory underlying the clinical presentation, but also the treatments. Your goals for this section of the module in this is to come away with understanding of the diagnostic criteria for bipolar disorder. So the DSM-5 diagnostic criteria. What makes a manic episode? What makes bipolar disorder? When you're reading through static, you want to pay attention to the kind of the demographics, the information about typical age of onset. Are there gender differences? Are there certain comorbidities that you might see? What is the typical course? Are there gender differences? Are there age differences in presentation? So that's the kind of stuff you get from static. We also want you to get an understanding of the typical means of treatment for bipolar disorder. Are there certain medications that we tend to use? Are there certain side effects or warning messages associated with them? Any patient education and any kind of screening tools or methods to aid with the diagnosis. That's really sort of the objective. Someone had mentioned having not treatment objectives, but learning objectives. That would be those. So let's go ahead and get rolling on this. Bipolar disorder. It's a natural follow-up to learning about depressive disorders. Stahl talks about unipolar versus bipolar. Is there a spectrum of mood disorders? And that is probably more accurate. He mentions many more than bipolar 1 and bipolar 2. Excuse me. He mentions 3 and 4, 1.25 and all this. And, that's fine. There's not a clear cut, this person's bipolar 1 and someone who is bipolar 2 is going to be night and day completely different all the time. It's just not that easy to categorize, and there's a lot of variety even within the different labels. So the best way to approach this is to memorize, to encode into your brain, well, what are the symptoms that I would be looking for? What would I be listening for? What would I ask about? The main thing that distinguishes a bipolar disorder from a unipolar depression is the presence of mania, is the presence of too much. So if you know what to listen for mania, then you can automatically distinguish a bipolar disorder from depression. So manic episode, what is that? It's really normal human behavior just turned up a lot. The person is going to they're going to talk too much. They're going to talk too fast. They're going to talk too loud. They're going to switch topics. They'll have trouble staying on one thing. Easily distracted. Their self-esteem may be through the roof. They may smile. I mean, their affect may be inappropriate. They may laugh. They may joke. They may believe that they're special and important, that their life is so awesome and it's so great, and people just, I just love life and I just want to go out and I want to do things. They do too much. There's an increase in goal-directed activity. There's more energy than there really ought to be. There is more desire. There is more interest than there should be. This may be reflected as an increase in engaging in activities that are very pleasant, things that hit the nucleus accumbens, things that are pleasurable. This could be sex. This could be gambling. This could be spending money on other things. This could be risky behavior like driving too fast, like sexual indiscretions, sleeping with lots of people, having affairs when this is not typical behavior for the person. It has to be, you see the first little dot right here, which is how do I say? The primary feature. That's what I'm looking for. The primary feature of a manic episode is abnormal. So this is a departure of normal behavior from the person. This is not typical for them at baseline. It's abnormal and it's persistent. It's not here today, gone 2 days, kind of got wild last Saturday afternoon, but then I toned it down Sunday to Tuesday. Oh, but now I'm back up. No, this is atypical for the person's baseline. This is persistent. They are elevated. They're up. They're good. Things are great. Things are wonderful. They're euphoric or they're irritable. Because with mania, the person might, the increase in energy, the increase in goal-directed activity, it may not be pleasant. It may be really irritable and easily frustrated and explosive and more prone to arguing, more prone to fighting. So a lot of energy, but not necessarily pleasant. So you have to have 1 week, that's your primary feature, at least a week, elevated, euphoric, or irritable, and 3 of the following. Now there has been a change from the DSM-4 to the DSM-5 with requiring a change in activity, an increase in goal-directed activity. That didn't used to be required, but now it is. That the change in behavior should be objectively observable to other people. That a person can't come in and say, boy, I'll just have so much energy. But behaviorally, clinically, that's not translating to anything. That was an attempt to eliminate a lot of false positives for mania, because people would say, they would report this sort of internal sensation of increased activity, impulsivity and such, but it didn't translate. So it requires an actual change in activity. Look through the DSM-5 criteria, because this requirement of mania is distinct from, in the DSM-5 is distinct from 4, that they require, if the mood is just irritable and it's not grandiose or expansive, then that requires further assessment. It actually requires an additional symptom criteria to count. And it has to be objectively observable to other people. It can't just be this internal sense of, yeah, I'm doing all these things, but you don't see it on the outside. People can't control mania. It is beyond their control. It's going to be observable to other people. They can't have it but then cover it all the time. That's not how that's going to go. Significant impairment for bipolar 1 disorder, which is what we're talking about here. Bipolar 1 disorder requires the presence of a manic episode defined here, according to the DSM-5. Like all of them, it requires significant impairment. So with bipolar 1, if someone is having meeting full criteria for a manic episode, they're going to end up in jail or in the hospital, voluntarily or involuntarily, and they will probably start experiencing psychotic symptoms as well. Delusions of persecution, delusions of grandeur. They may start hearing voices. That bipolar 1 is an acute, a manic episode is acute psychiatric illness that requires a medical intervention. It would be like someone who is actively psychotic, someone with schizophrenia who's actively psychotic. Bipolar 1 is not something you will successfully just cruise through your life experiencing. This is acute. It's a reason a lot of people are on an inpatient unit, because it requires medical intervention. So when you're working with somebody and you're starting to kind of wonder if maybe maybe they're hypomanic now, and hypomania, which you'll see in the DSM-5 as well, or in SATIC, is a hypo under. It's a less severe form of mania. It doesn't have to last as long. It needs to be persistent daily, but only for about 4 days. It does not cause clinically significant impairment. So if someone has experienced a hypomanic episode, they will probably be talking faster, only needing to sleep a couple hours a night. Things are great. They're getting a lot done. They repainted their house. They've reorganized their cabinets. They're going into work early. They've started a new workout project. But they're not tipping off the authorities. They're not getting into fights in public. They're not psychotic. Absolutely not. If someone is having symptoms of psychosis, then you can count hypomania out. But it doesn't require intervention, and other people would notice, but it's not going to get them into trouble. That's really the distinction between mania and hypomania. And by trouble, I mean it won't get you arrested or involuntarily committed. Usually people really like hypomania. That's the problem with it, is everything feels good, everything is fun, people are active, they can get so many more things done, and just it is this artificial chemical environment in the brain making everything seem like a great idea. That's real different from mania. That's real different from what we're talking about here. Mania is a problem. It's a serious problem. So if you're talking to somebody and you're kind of suspecting hypomania, you will want to ask them, historically, have they ever had a manic episode? So you would want to know, have you ever been in the hospital? What's your legal history? Because if someone has been in the hospital before for what seems to be elevated mood, then that was more than likely bipolar 1 and you're dealing with mania. Maybe not currently, but that's in their history, so that may cycle back around again. And we mentioned DSM-5, emphasis on observable activity. Bipolar 2, and we're talking about the F code. Bipolar 2, there's only one. There's only one in the DSM-5. Only one F code, you got to know for that. Again, similar primary feature, shorter duration. It's not as intense, it's not as severe. It has to be there for at least more than half of a week, meaning not just I had a good day or two. And that's really what Stahl is talking about, is maybe there's a lot more variance on the spectrum of mood disorder than we think. So if you meet criteria for hypomania for 3 days, then that means you don't have anything? No. It just means you don't reach the threshold of bipolar 2 disorder, which is relevant because treatments have been investigated and established according to folks who hit that threshold. You don't want to be prescribing treatments that have been studied for disorder A. You don't want to give those treatments to people who are not compatible with disorder A, because you don't know what it's going to do to them. You can't say for sure it's going to help. So that is really the importance of diagnostic accuracy, is because it points you to treatments that have been researched and more or less proven to help. Cyclothymia is an interesting disorder. Cyclothymia is really a cycling combination between hypomanic episodes and sub-depressive episodes. People will go through distinct periods of mild mood elevations, and then a while down the road, they'll go through distinct periods of, well, it was like a week and I just didn't want to get out of bed and I didn't shower a few days and I called into work and was feeling pretty down. But, after about a week, it kind of went away. And I say a week because they don't meet criteria for a major depressive episode. That would require a diagnosis of major depressive disorder. And they don't meet criteria for really a full-fledged hypomanic bipolar 2 kind of thing. Because really, if you had hypomania and then down the road you met criteria for a depressive episode, then you would be diagnosed with bipolar 2 disorder. So there's evidence of hypomania, but no clear meeting of criteria for MDD, for a major depressive episode. Cyclothymia is like subclinical depression, subclinical mania. It cycles maybe once or twice a year. There is a Stahl will talk about rare. You have rapid cycling bipolar disorder. And when they say rapid cycling, they don't mean I'm manic today and I'm depressed tomorrow and then next Thursday I'm manic again. That's not, I mean, physiologically, the chemicals in your brain required to drive those sort of mood and energy and cognitive changes, they don't reset and redo overnight. You're probably dealing with more of some kind of personality or substance related disorder there. But rapid cycling would be more than 4 episodes of mania, 4 mood elevation episodes in a year, not in a week, not in a day. So even rapid cycling bipolar disorder, the variance from elevated mood to depressed mood occurs over very long periods of time. And most people with bipolar disorder don't have rapid cycling type anyway. So don't be thinking, oh, I think this is bipolar and rapid cycling. No. If it changes, they were manic last week and depressed next week. That's just not physically how it works. It would be like making let's adjust your levothyroxine level and let's recheck it tomorrow to see if it's better. That just is not the pace with which changes occur hormonally in the body. So you want to consider substance-induced mood disorder because any kind of stimulant can look like mania. Cocaine can do it. Meth can do it. So just because somebody comes in talking fast and oh my gosh, they look manic, first thing you got to do is rule out substance, because bipolar disorder is just not, it's not the most common disorder ever in the history of the world. It's significantly less common than a unipolar depressive disorder. And it's much less common than the rate of substance use disorders on the planet. So you definitely want to rule out the use of a stimulant. There are screenings for this. You can Google this. There's a mood disorder questionnaire, which is, I think, maybe 12 or 13 questions that you can ask a person. It can be clinician administered. And if there are a significant number of yeses, then you might really consider that this is a bipolar disorder. A lot of your evaluation and assessment for this is going to come from the mental status. It'll be observing and listening, watching the person. And if someone is acutely manic, it will be difficult to get them to answer a questionnaire and to stay focused on questions and not interrupt you and stay on task. There's also a rating scale for peds. The Young Mania rating scale for children up to adolescence is mainly when it's been normed for, and parents can fill that out. But the best screening for this is to know the criteria and to know what questions to ask and what to look for. We kind of mentioned, and we'll talk more about this over the spring, that bipolar disorder in younger people, there will be difficulty falling and staying asleep. There may be an increase in activity. You may see, from the impulsivity aspect, some hypersexuality, increased interest in sexual kinds of behaviors. There's aggressive storms, not necessarily constant, but that impulsivity, increased energy, disinhibited, will be tantrums that last a good while, and more difficulty returning back to normal mood. And this has to be different from the child's baseline. Always, like with any adult, with anybody, it's different from baseline. Kids may present as irritable, but again, irritability in children is more likely to end up in a depressive diagnosis into down the road. Longitudinally, they find that irritability in kids ends up being more of a unipolar mood disorder. But they may present just kind of silly, goofy, just happy, laughing, joking when the stimulus in the environment really is not, would not typically evoke that behavior in the child. Mania in kids is much less common than ADHD, than oppositional defiant disorder, than more of those behavioral disorders, disruptive mood or impulse control, unspecified, those kinds of things. So you don't want to jump to, oh, this child is very active and they're irritable and they're blowing up and having tantrums above and beyond some of the time, and they're not sleeping. You certainly would want to include bipolar disorder in your differential, but don't let that be your number one consideration. As with any presentation for kids, you want to look at the recent history. Have there been significant environmental changes? Is there a family history of bipolar disorder? Because it is higher genetic loading for bipolar to manifest in a proband, meaning a first-degree relative, than really any other disorder, schizophrenia and bipolar disorder. If you don't have a family member with mom, dad, brother, sister, grandma, grandpa with diagnosed bipolar disorder, then you would not want that to be your primary differential there. Bipolar disorder typically does not present in children or adolescents for the first episode. That's more of a 20s and 30s kind of thing. It doesn't mean it's impossible. It just means there is likely an alternate explanation, especially in the absence of a family history of that. With adolescents in particular, you want to look for a substance use component for sure. But otherwise, the symptoms, the actual symptoms of the criteria for a manic episode in an adult versus a child, there's no different criteria. So you're still looking for the same thing. More distracted, more active, not sleeping, impulsive. What makes this different from maybe a behavioral disorder, which tends to be behaviors that are evoked by stimuli, it's more of an action-reaction kind of thing with behavioral, with ODD, with intermittent explosive, is that there's continuous periods of illness that a younger child who's kind of silly and goofy and kind of physically maybe asking questions about sex, maybe talking faster than usual, talking more than usual, more distracted than usual. That's not going to come and go and come and go. It's the irritability is going to be there and it's going to stay there. The tendency toward emotion dysregulation is going to be more consistent versus more it comes and it goes based on if I'm being corrected or if somebody was mean to me or I'm that kind of thing. It's not as come and go based on stimuli in the environment. And irritability, as opposed to the happy, wonderful, euphoric irritability, needs to be considered in the differential when you're seeing that. you want to consider bipolar disorder. You really want to consider depression as well. But the difference is activity, because with depression you see reduced activity, reduced interest, withdrawing. I don't care. I don't do that. Not speaking when spoken to. That is not what mania looks like. So keep in mind those big differences. Is it normal human behavior turned up? Is it normal human behavior turned down? Because one looks like depression and one does not. Typical onset, it's a mood disorder. Usually in the 20s or the 30s, the first episode of someone who has bipolar disorder, who ends up with a diagnosis of bipolar disorder, they're more likely to be, the first episode is most likely to be depressed. So if someone's never been in treatment before, never had a mood episode before, the first one they're going to have more than likely will be depression. It's rare for the first mood episode to be manic. But if the first episode is manic, that's more likely to happen in men. So women are more likely to be diagnosed with depression, generally. Men may have a greater likelihood of experiencing a manic episode first than women will. Women more likely to have bipolar 2, meaning, again, depression with bipolar 2. Depression is the kind of the bigger picture. They never raise up to full mania. There is some significant mood elevation, but not manic. So mania just may be a more likely presentation in men than it will be for women. Depression just tends to be more pronounced in women. High genetic loading. Probands, you want to ask about family history. There's a good chance that there is comorbid substance use disorder, particularly alcohol. People are trying to slow themselves down and calm themselves down. Also comorbid with panic and obsessive compulsive disorder. And panic and OCD are well, it's kind of interesting too that OCD is highly comorbid with schizophrenia. And it's also comorbid with bipolar. So that's interesting. High rate of relapse in the first year. Remember, hypomania feels great. There will be maybe some reluctance to stay on medications, especially because the medications make them feel very, very different than even they did at baseline. From a treatment standpoint, what is the cause of, what is the underlying mechanism of bipolar 1 disorder, which might involve depression, it might involve mania. They're not exactly sure. But the going theory is that this could involve overactivity of dopamine. Hey, that's pleasure. That's impulse. Too much norepinephrine. That's, is that energy? Is that overexcitability? Glutamate is the primary excitatory neurotransmitter. So when glutamate lands on a NMDA receptor on any neuron, that neuron's probably going to do something. So the idea that glutamate overactivity is causing overactivity of everything else, too much awake, too much energy, too much activity, too much thinking. That makes sense, that maybe it's a too much sort of issue. We also know that glutamate overactivity is associated with seizure disorder. Medications used to treat bipolar disorder are often anti-epileptics. So the medications used to treat bipolar mania specifically are the same ones used to treat seizures. So GABA is our primary, that's the neurotransmitter that tends to slow down and lessen activity of other neurons. We talked a couple weeks ago about serotonin tends to increase GABA activity in some areas. So serotonin can be calming in that way because it makes GABA increase its calming activity of other cells, of other neurons. If you don't have enough GABA, then maybe you have too much activity. Sodium, potassium pumps, Is it voltage sensitive sodium channels? Is it voltage sensitive calcium channels? And again, the sodium potassium pump is what allows for re-stabilization of the neuron. When we talked about that electrical activity that travels down the cell and allows the incoming message to go to the other end of the neuron and cause it to fire. For that cell to get back to its resting potential, kind of resting again, ready to get activated again, that's a sodium potassium pump issue. Is it not working right? Is it not ever reaching its resting potential again? Is it just staying kind of prone to fire, prone to fire, prone to fire? You also have sodium, voltage sensitive sodium channels, which is the actual what allows the cell to fire. Calcium channels, which allows the release of monoamines at the terminal end of the cell again. I'm going to see if I can't. Let's see. I'm trying to do something technical here, because I'm so technical. Except that I'm really not. Okay. Hot diggity dog. I wanted to pull up that little picture of that little cell again. Let's see if we can do that. There we go. Right. So this little cell again, remember we talked about the neurotransmitter from the cell on this end lands on this receptor on the somatodendritic end of our neuron, and it causes whatever change it's going to cause. It could be G-coupled, G-protein linked, it could be an ion channel, regardless. It initiates that action, the action potential, which makes its way down the cell to the axon terminal, where more neurotransmitters are released to activate this cell, to send a message to this neuron. And the action potential, that electrical impulse, travels all the way down the axon. That's how it gets from the soma to the terminal end, where it can send its own messages to this next neuron. And you have voltage sensitive sodium channels along here, along the axon, which senses that electrical change and lets more sodium in. And that is how the inflow of sodium changes the electrical charge in the cell, which allows that magical negative 55 action potential that allows the electrical current, for lack of a better term, to travel down the axon and trigger kind of the neighboring cells. If I let so if the cell here hits the negative 55 action potential, millivolts negative charge, then that's enough to cause the switch of sodium to flood into the cell all the way down to where you have the electricity, the electrochemical gradient is changed for the length of the axon until it gets here, and that electrical change allows for other, actually for calcium channels at the terminal end to open, which allows for the neurotransmitters to be released from the terminal to activate the soma of the next neuron. It's critical to the functioning of the cell that it stay the resting potential. We were just talking about action potential, but the resting potential of the cell just means it needs to stay sufficiently negative enough that it's not going to fire. Because if it gets a little bit more positive and the electrical charge in the cell becomes negative 55, if it becomes a little more positive, then that's enough to trigger that sort of domino effect of, oops, all of these cells going, all the channels from this end to this end, they will get opened and sodium will come in and the electrical charge will just travel all the way down and activate this cell. If this neuron here, where the little finger's pointing, it needs to stay sufficiently negative and resting, or else it's just going to keep firing. Because if it becomes a little more positive, that cues that domino effect of the positive charge travels all the way down the membrane and releases its neurons, releases its neurotransmitters. One of the ideas behind bipolar disorder is that the cell, or cells more than likely, many neurons, never quite reset themselves back to that resting potential, that they never get all the way negative again to where they're at rest, and it takes a good charge to make them fire again. A thought with mania is that there is a problem with the voltage sensitive sodium channels, that they're just letting too much sodium in, that they are keeping the electrical gradient of this neuron a little too low, kind of like a hair trigger. It's never getting fully reset. So any little impulse that comes down the road, boom, that's enough to send it on. So there's just this constant firing. And it all has to do with cells returning to their full resting state, to where it takes a good solid impulse to get them to go along to the next, to fully release, to fully engage. So you can see how if there's a problem with these sodium channels kind of letting too much sodium in, the little cell is just always itching to fire along and do something, that maybe it would help to correct that. So is there a way to help the neuron reestablish a good negative charge, a good resting state? Is there a way for us to do that? And yes. So let's pull this bad boy back up. Voila. So I just wanted to pull that up again to describe how the sodium channels, which allow cell depolarization, i.e. cell activation, if those critters are overactive or they're letting too much sodium in, we got to correct that, or else they're just going to be too prone to fire. And the system will be kind of in constant activity, which is what seizures look like. It's cells that are firing in a disorganized manner, in a destructive manner. It's really dangerous for the actual health of the actual neurons, because if they're constantly firing, then that means they're not ever trying to repair themselves. Waste is going to build up. There will be altered connectivity downstream. As far as downregulation, cells die. It's destructive. And we know when after folks have seizures, or when people have psychotic episodes, that cognitively they don't ever return quite back to where they were before. It's dangerous. So we need to slow down this overactivity. We need to slow these hyperactive cells down. Maybe we can boost GABA, slow it down that way. Maybe we can correct the electrical impulse sensitivity by addressing sodium channels. Maybe we can just straight up block norepinephrine or dopamine receptors. Maybe that'll kind of put the fire out a little bit. And, that is exactly what we do for the treatment of this. Someone who's acutely manic, someone who is psychotic, someone who's not sleeping, someone who is disorganized and impulsive and volatile, need to be treated with a mood stabilizer and a second generation antipsychotic, because mood stabilizers can take a while to exert their beneficial effects. Second generation antipsychotics will induce sedation, can help people sleep, can help people rest, can slow down this overactive mind, can reduce impulsivity and agitation, to slow them down immediately. But you got to get a mood stabilizer on board, because a second generation antipsychotic may block norepinephrine and dopamine and other things at kind of at the last, as a last straw. But they're not addressing the issue with cell hyperexcitability in that electrical that tendency for excess activity in the neurons. All they're doing is blocking the end result of that activity. Someone who is not severely ill, you may be able to initiate just lithium or Depakote, and LI is lithium, Val is valproate, which is Depakote, main mood stabilizers. So someone who is less ill, maybe you could do one or the other, because second generation antipsychotics are indicated in the treatment of mania, and some even with bipolar 2 disorder. And then for maintenance, the go-tos are really lithium, Depakote, Lamictal. Another big one, it's not listed here, is going to be Tegretol as a mood stabilizer. Now, Depakote can be used for acute maintenance. Tegretol can acute maintenance for acute treatment, acute management. That's the M word I meant to say. Tegretol can be used for acute management. Lithium, Lamictal, not so much. Just remember, if someone is impulsive and fighting and not sleeping and can't hold a conversation, they're so distractible, they're very, very short-fused, difficulty with any kind of regulation or impulse control, you want something that will be for their protection and others. You need something that's going to slow them down quick. And lithium is just not going to do that. It's a great medication. We're going to talk about it. But for someone who's acutely ill, that's not sufficient. In some cases, it's believed that antidepressants can uncover an underlying bipolar disorder. If you're working with someone, and there is actually some debate on that, but if you're working with someone who is taking a whole bunch of an SSRI or a whole bunch of an SNRI, and you are starting to notice that they are exhibiting symptoms of mania, then you would need to get them off of the antidepressant, stabilize the mood, and then potentially add it back. But you want to get that out of the picture. This is what we just talked about. Atypical antipsychotics, especially if the person's having paranoia or auditory hallucinations, or they're really convinced that they're a special agent working for the government and they need to talk to the new governor about their plans to fix Birmingham infrastructure, then okay, you want to correct that thought disturbance, kind of where the rubber meets the road, while you are correcting the underlying mechanism, which is that just overly excitable cells, that glutamate, potentially glutamate, hyperactivity causing cells to just stay too active. Depakote, lithium, SJs. Hospitalization, if they're a risk, they're a threat to themselves or other people. If they're having impaired reality testing, meaning delusions or hallucinations. Is there a lot of substance use going on? Is the person going to continue to have access to those substances if they don't go in the hospital? Are they, the main issues with hospitalization is you got to prove, I think it's 4 things. 1, that they have a diagnosable mental illness. 2, that the illness is going to get worse if not intervened. And the person is not aware that they're in need of this care, and care is available. So those are the things. Those are the things that you have to prove, that they have an illness, they're a risk to self or others, they're not aware of this deficit, they'll get worse if not treated, and treatment's available. So that's the main components. Because you can imagine folks with mania, they may, if they're speeding, if they're getting tickets, if they're getting in fights with strangers, if it may get to where they're not eating, and they're never locking. A spouse may come in and say, my husband is just, he's talking to strangers and spending all of our money and speeding, and he's not wearing a seatbelt, and he's speeding in school zones, and he's bringing people I don't know to the house. And it could be any number of things, but you consider the clinical impact of this, and are they a risk to themselves and to other people? And if they meet those criteria, you can get them in a hospital. So lithium, gold standard, been around a long time. It tends to reduce episodes of mania. It may also even boost depression, which is great. That's the ideal mood stabilizer, is that it would prevent the highs and prevent the lows. Stabilizes the membrane potential, what we were talking about. Allows cells to get out, to stabilize the sodium and the potassium, to re-establish that resting membrane potential, that more negative internal environment, so that the cell isn't just firing and firing and firing. Something else that's interesting to consider is that if the neuron is never sufficiently at resting potential, then it will be more likely to fire with a less intense stimulus from another neuron trying to tell it to do something. But you can imagine that the force of the impulse that own cell can generate will be less, because it is not returning to as substantial a resting state. So the amount of impulse that it's going to be able to generate when it is active is going to be limited. It's only going to be able to produce, a lower voltage signal, because it didn't really build up much momentum to send a stronger signal. So more firing, maybe less, at a less amplitude. Could that be one of the reasons why lithium helps with depression? That by allowing the cell to regain its full strength, its full resting potential, does that allow for it to not only fire less frequently, but with more force? Would that allow for, will that correct some downstream neurotransmitter release to promote a more positive mood? Is that frequent firing actually reducing that cell, that neuron's force to release mood promoting chemicals downstream? Potentially. So it's kind of the theorized mechanisms of action of lithium is that maybe it improves, it's able to land on some of those G protein coupled receptors. Does it change metabolic activity in the cell? Does it interact with those sodium channels to slow down repolarization so that the cell can actually, can reestablish its resting state, its full strength, its normal frequency. Maybe so. Because again, lithium it's just a cation. It's just a positively charged. It's an element, kind of like sodium. So it would make sense that it would interact with sodium, which is particularly relevant when you talk about baseline labs, GFR, BU, and creatinine. Other things that lithium as an element does is it interferes with the activity of antidiuretic hormone that your kidneys may be less responsive to antidiuretic hormone, so your brain's attempt to keep water on board will be limited by the presence of the lithium. So people may notice they're peeing a lot. They're thirsty a lot. Well, that has to do with lithium's interaction with urine concentration in antidiuretic hormone. Real important that you know how well the kidneys are filtering proteins and sodium and lithium, because you don't want lithium to back up in the system from from impaired renal functioning, because lithium's ability to stabilize the membrane of neurons, it tends to promote cells returning to rest. That's what lithium promotes, cells not firing, but more returning to rest. That if you have way too much lithium, then you may have way too much cell rest. You may overly inhibit neuronal activity, which can result in trouble with, when you look at the side effects here, you may get dizziness, sedation, stupor at higher levels, being uncoordinated, being clumsy. That is not a typical side effect. The typical side effects of lithium, there may be a fine tremor, which I put here twice, I'm not really sure what. Nausea, it hurts people's stomachs, tends to. So maybe some indigestion. Just tell people to take it with food, take it with a snack, and that tends to resolve it. And a goiter, something else that lithium does in the body, you see TSH up here, is it interferes with thyroid stimulating hormone, trying to communicate with the thyroid to, hey, convert some T4 to some T3, please. Give us some active thyroid hormone in the body. It also directly interferes with the conversion from T4 to T3 to the active state. So if your thyroid's having to work harder to maintain a circulating blood level of active thyroid hormone, then you're going to get a goiter because those cells are going to increase their efforts. They'll upregulate because they have more work to do. So you want to check a thyroid, TSH, and a free T4 before you start, and then you'd want to check it a couple of months down the road after you've initiated it. And you just monitor this. There may be an increase in those levels, but if the person clinically is not, they're not showing signs of hypothyroidism, then you don't necessarily need to do anything. And you'd probably mainly, if you're working closely with the person's primary care physician, maintain communication with them. If you check a level, let them know what it is. Lithium can alter cardiac repolarization. So you want to check an EKG at first. And it is teratogenic, so you would not want to initiate this on a mom with a baby on board. So renal clearance, diuretics, NSAIDs, anything that's going to impair kidney functioning be that blood pressure medicines, certain diuretics, NSAIDs. Be very cautious. Usually you'll start about 300 twice a day. That's kind of standard. You check a lithium level, give it 5 days, get to your target dose, which for most people probably you would just start at 300 twice a day. And after 5 days, check a level, 12 hours since their last dose. So they take it at bedtime, check it in the morning before they take their next dose. You're shooting for 0.6 to 1.2 milliequivalents per liter. 300 twice a day may not be sufficient to get the person there, but that's why you check it, just to see how that's going to work. I'm working with several folks who take a total of, actually one's taken 300 twice a day, and another, I'm just thinking off the top, one person's only taken 450 total a day, and they're both, one's at 0.6 and one's at 0.8. So it's very patient specific. So just start 300 twice a day, check it in 5 days, adjust up as you can. Depakote or valproic acid or valproate. There's an immediate and an extended release of this. Depakote is much more sedating. It's much more, it may be more likely to cause kind of some cognitive slowing for people. It works also by trying to stabilize the sodium channels along the membrane to help the membrane potential get sufficiently negative at rest, not just overfire at a weaker kind of signal. It may also allow more GABA to be available. It might, and this is, again, they don't really know, but some theorizes that it prevents GABA from being broken down. Maybe it prevents it from being taken back up. So Depakote, GABA, calming, stabilize the membrane potential. Can help with a lot of times anger, explosive anger, blowing up. It's sedating, so it can be given at night. Baseline liver function, CBC platelets. Depakote is extensively metabolized in the liver, and there seems to be folks with a genetic predisposition to not metabolize or to metabolize Depakote into certain metabolites that are hepatotoxic, that maybe cause cells to oxidize more, that it may actually inhibit some of the enzymes that are trying to break it down in the first place. So not everybody has has signs of liver enzyme elevation with Depakote. Not everybody does, but there seems to be something genetic predisposing people to those injuries. And again, they don't really know what it is, but they're suspecting that it's some metabolite caused by some people's CYP conversion of this drug. So you would monitor that up front. And if the person already has significant, history of hepatitis or cirrhosis, then you may not have this be your first go-to, or you may just start it at a much lower level. And again, that's genetically, they're finding perhaps a genetic link for that. Big side effects with it, we talked about liver for some, so you monitor it. But also weight gain is real common for people, and there seems to be folks who are taking Depakote may have increased levels of insulin, which all insulin wants to do is store sugar as fat. That's what insulin wants to do. So people on Depakote will report being really, really hungry, which you can imagine will lead to increased feeding behavior and increased insulin levels. So you may want to include dietary education. in particular. Typical dosing for this, starting off around 25 milligrams per kilogram per day. That's a healthy, that's a healthy dose right there. That's sort of that's your target. Let me say that. You're going to start off by calculating the person's kilograms, and you're going to come up with a target that's about 25 milligrams per kilograms per day. Most folks will start, and the American Psychiatric Association has dosing guidelines, start maybe 500 to 750 milligrams a day, depending on the acuity level, and you've cleared all their labs and they're fine. They don't have an extensive drinking history. They're not taking other hepatotoxic medicines, and you could start maybe 500 twice a day, 500 at bedtime, 250 in the morning. There's no magic to this, but you want to start somewhere in the 750 range in divided doses if it's your immediate release. And you're shooting for that 25 milligrams per kilograms per day. You can titrate up every few days depending on tolerance. Is it causing some stomach discomfort, or are they just excessively sedated? Safe bet starting 750 or so. You can dose most of it at night. Kind of another provider I've worked with has said, yeah, just take their weight in pounds, add a 0, and that's going to be their target milligrams per day. And it actually kind of works out pretty close. But if you want the proper, it's 25 mg per kg per day, not to exceed 60 mg per kg per day. Your target dose is 25 milligrams. Let's say you start them at 750 at bedtime. In a few days, you up it to 1,000. In a few days, you up it to 1,500. And then you get to, let's just see how this person's going to do at 1,500 at bedtime. You get them to that dose. You wait 5 days, and you take a trough level. You let the steady state get established. 5 days. Same for lithium. Get to your target dose, wait 5 days, take a level, which with Depakote is a trough level. So you want to get it as close to when they have to take their next dose as you can. And there's your 50 to 125 about is the blood level associated with therapeutic effect, but no side effects. Sedation and weight gain. LFTs up front. This is also teratogenic, not for women who are pregnant. And then you want to check labs. And what I usually do is, let's say I'll check it after 5 days, and if I'm okay with the level, I'll wait, because they haven't been on it very long. If I have the option to get them to come back in a week or two to check it again, to not only check liver function, but also Depakote, then that's what I'm going to do. And if that is steady where I want it to be, I'll push that out to about a month, and then we can go Q6 on that. But you want to monitor pretty closely at first, your initial, and then after a week or two, if you can, educate the patient about indications of liver problems, change to skin, change to stool, abdominal pain, bruising easy, those kinds of things. Lamictal is not for acute maintenance, which Depakote would be. I keep saying maintenance, I apologize. Management, acute management. Lamictal, not for acute management. It takes way too long to get people to the target dose, which is somewhere in the neighborhood of 200 to 300 milligrams. You can go as high as 400, but usually folks stay in the neighborhood of 200 to 300. Helpful for bipolar depression. Very slow up titration. 25 for 2 weeks. This is the most conservative approach. 25 milligrams for 2 weeks, then 50 for 2 weeks, then 100 for a week, and then you can increase by 50 to 100 milligrams weekly thereafter. The big concern with Lamictal is this systemic reaction, Stevens-Johnson syndrome, which is not just a little flaky, itchy red bump rash. This is more like wheals. This is This is painful, swollen areas of the skin. A lot of it'll affect mucous membranes sometimes, so folks may start having problems on their mouth, lips and mouth. But this is not just an itchy rash, like a dermatitis thing. This is painful wheals on the body that you want the person to stop the lamictal and either call your office or go to the emergency department for evaluation. But the main thing is if they notice painful areas on the skin, stop it. Let you know. Go to an emergency department for evaluation. People are genetically predisposed to have this response to lamictal, for it to trigger essentially a kind of an autoimmune inflammatory response. There's genetic testing you can get to see if people are more likely to have it. And by titrating up really slow, you allow for adjustment, and this is less likely to occur. So you don't make huge lamictal adjustments quickly. You want to go very slow. And actually, Depakote tends to increase lamictal levels. So if someone were on some drugs can induce lamictal. So certain antiepileptic drugs, you may actually need to increase your lamictal, but Depakote can increase lamictal levels, and you think, oh, well, I don't want it to get increased too quickly because of that, the SJS potential. So be very cautious. Avoid, if possible, combining lamictal and Depakote. Second generation antipsychotics. Oh, I didn't mention Tegretol. I apologize. I'll backtrack on that real quick. There's not a slide for it. But Tegretol is another, it's an antiepileptic drug. It's commonly used for acute management of mania, so it can slow people down pretty quickly. It's believed to work also by helping reestablish a resting membrane potential. It stabilizes the sodium channels that are responsible for sending that impulse down the line. Slow it down, let it get more negative, rest. The big concern with Tegretol, and probably why it's not used a ton, it does require lab monitoring for a Tegretol level, and some of its metabolites are believed to the agranulocytosis. So the white blood cell can be decreased with Tegretol. So there's the risk for infection. And the suspicion is that one of the metabolites of Tegretol directly causes injury to neutrophils in the system, that it may cause them to oxidize and die too quickly. It may impair the kind of the energy metabolism in the cells, so they can't maintain. You need ATP for pretty much everything to happen in your cell, including getting nutrients in and out. So that is the big concern with Tegretol that makes it not as popular as some of the others. That, like I said, the risk for infection with agranulocytosis and the monitoring required. But can be helpful for management of mania. So those will probably be the main ones that you'll see: Depakote, lithium, Tegretol, lamictal. Different indications. Second generation antipsychotics can also be helpful for mood stabilization because they slow things down. They slow down thinking, they slow down activity, they slow down aggression and impulsivity, they help people sleep. And this is just a little slide with some different second generation antipsychotics with indications for bipolar 1 disorder. And then you have Latuda down there on the bottom, indicated for bipolar depression. So you've got Seroquel. Seroquel is a good one because it is so sedating with the antihistaminic activity. It behaves differently at different doses. So you can imagine you'd probably need a higher dose, or especially if someone's having with bipolar mania with psychotic symptoms. But the anticholinergic activity contributes to weight gain, which may not be appropriate. Abilify, I don't think you'll see Abilify used a whole lot for bipolar 1, certainly not for someone who gets acute mania. This isn't going to stop someone if they are currently manic. Maybe it'll help present it, but I would say for a more moderate presentation, someone with perhaps more impulsivity, but not aggression, not disorganization, not thought disorder symptoms, so the delusions and the hallucinations. Abilify just is not heavy duty artillery here. Zyprexa is very sedating, tremendously sedating. Olanzapine, quetiapine, it's no surprise really that they are both sedating and both anticholinergic as far as contributing to weight gain. Very sedating, can help someone sleep really quick. But, and again, these are indicated for acute mania. So if someone is currently manic and they need to be stabilized, sure. These are technically indicated for maintenance, meaning prevention of down the road manic episodes. But when you look at the metabolic side effects of this, the risk-benefit standpoint would probably be better to have a combination of an actual mood stabilizer, a lithium or a Depakote, with this, perhaps to help with sleep, maybe to help with, I don't know, some more impulsivity if they have a history of thought disorder symptoms, but metabolically a concern. Blood pressure, sugar, triglycerides, those kinds of things. Risperdal, absolutely, been around a long time. It's cheap. Latuda is not. Say you have somebody who you're more concerned about weight gain, Risperdal may be a better choice than the Zyprexa. I think Geodon is indicated too. I didn't include it here. In Stahl's book, in Stahl's prescriber guide, you can see the indications, all the drugs and their indications. And really, most of these antipsychotics have indications for as acute or maintenance drugs for bipolar 1. You would not do these medicines for bipolar 2. That's a bit much. If someone is only ever hypomanic, this would be over the top. This would not be really justifiable. I think Seroquel XR has an indication for as an antidepressant, so that would make sense. Latuda has indication for bipolar depression. That would be justifiable if they can afford it. Latuda is really expensive. And similar to Geodon, Latuda needs to be taken with food to maximize absorption and therefore bioavailability. And Latuda is quote-unquote pregnancy category B before they got rid of the lettering system. It's as safe for pregnant women as Zofran, I guess. For mood elevations in childhood and adolescence, several of these drugs seen here do have indications for acute management and maintenance. You see it's just lower doses to start, but the upper range is almost about as high as it goes for adults, but you just start lower, you titrate up more slowly. This would be devastating, I would imagine, for a family to have a child diagnosed with a psychiatric condition as serious as bipolar disorder because of the the behavioral changes, school, appointments, things that tend to be really helpful for preventing down the road episodes are things that help pretty much everybody. not exposing people to excessive amounts of stress and change and conflict. Predictability, exercise, diet, coping skills, emotion regulation skills. So parents are going to need a good bit of they're going to need a good bit of support, and they will need to learn how to help kind of structure the home environment to be supportive of the kids' recovery. And of these, probably Abilify would be the least sedating, the least cause the least amount of cognitive impairment, be pretty well tolerated, help with impulsivity. This last slide is and this is, you've seen this obviously because this is the exact same thing, well, almost the same thing, posted in the course. For directing your study, you want to know diagnostic criteria for MDD, bipolar 1 and 2 disorder. Some things that we didn't mention, dysthymia, in the lecture. That's covered very adequately in SATIC. And dysthymia is really subclinical chronic ongoing depression. Cyclothymia is subclinical mood elevation and depression. You got to know the criteria, the typical comorbidities. SATIC will tell you about their brain structure differences, or their differences in age of onset, course of treatment, risk factors. That's all your SATIC information, which is really helpful in forming a differential when you're talking to people to know what tends to co-occur with these things. What's the usual onset? We want you to know rating scales for MDD, screening instruments, tracking instruments, PHQ, Beck Depression Inventory, the Mood Disorder Questionnaire for adults, the Young Mania rating scale for younger people, and then the medicines, labs, contraindications, patient education, adverse effects. I'm trying to think if there's anything else. That might be it. So please email me if you have any questions. I'll be at a conference next week, but I'll be checking email as regularly as I can. And we'll look forward to hearing from y'all. Have a good start to your week.